All right, good afternoon, everybody. Thanks for joining us for today's webinar. Today we're starting the first in the series of the hospital-acquired infections, and we'll be hearing from Dr. Walt Biffl from Denver Health, one of our partners. And if you weren't able to join us for the kind of kickoff of this bundle with our human factors expert, Frank Drews, that webinar was recorded and it is going to be posted on our website. Should be posted later today, and we'll be sending an email out reminding everybody of that to view and participate if you weren't able to live last week. So with that, I'll go ahead and turn it over to Dr. Biffl to introduce himself and the work on surgical site infections. Dr. Biffl?
Thanks, Jason, and welcome everybody. I haven't done too many of these webinars. It's a little disconcerting not being able to see any faces, but I'll imagine all of you out there eating your lunch and multitasking, answering email and things like that. But as Jason said, we're going to talk today about surgical site infections. So what I'm going to try to do is give you an overview of the problem, and it's going to be from a surgeon's perspective because that's what I do, but also try to help get everybody on the same page in terms of what we're going to try to accomplish with this aspect of the hospital engagement network. This cartoon that I'm showing you now depicts healthcare as being one of the more dangerous hazards we encounter. You see on the x-axis the number of encounters for each fatality, and the y-axis total lives lost per year. See that airline flights, nuclear power are relatively safe. But over in the dangerous category, we have bungee jumping, mountain climbing, and healthcare. And this is something that was really brought to the public's to the forefront of the public's knowledge about 10 years ago when the Institute of Medicine released its report To Err is Human. And in that report, they estimated that medical injuries result in as many as 98,000 deaths a year and $17 billion in health care costs. Again, from a surgeon's perspective, in this report, they looked at 44,000 operations over a 14-year period. Over 5% had complications, and nearly half of these complications were felt to be directly attributable to human error. So there is a lot of room for improvement and a lot of interest in quality improvement. And as you all know, what we're participating in here has come from the Partnership for Patients led by CMS and CMMI. And the surgical site infections are one of the core preventable harms that this Partnership for Patients is intending to address. So with today's webinar, what I want to cover is first an overview of the problem of surgical site infections. The fact that you're all here, I think, suggests that you care, but it might be just an assignment for you. So I'm going to tell you why you should care. I'm going to go over some basics of surgical site infections and then get into the aspects of prevention. And we're going to talk about how we get started, or some of the more basic aspects, our working harder category, and then for those of you who already have the basics down, then we'll talk about what we think is ahead of the curve in terms of prevention. Surgical site infections are one of the category of healthcare-associated infections. Those also include CLABSIs, catheter-associated UTIs, ventilator-associated pneumonia, and C. difficile infection. Surgical site infections are the second most common hospital-acquired infection after UTI. In surgical patients, nearly 3/4 of hospital-acquired infections are surgical site infections, and it's estimated that they occur in 2 to 3% of the 30 million operations that are done in the U.S. annually. So the scope of the problem is huge. The consequences of SSIs have been estimated in a number of studies, but something that's not disputed is they do increase costs up to over 200%. They do increase hospital length of stay up to over 300%. And depending on the population of patients you're talking about, they can have worse effects. And for example, in older patients that defined as over the age of 65, they have a 3.5-fold increased mortality risk. to go along with a threefold longer length of stay and twofold increase in hospital charges. The nationwide impact of this, if you estimate that there are about 300,000 infections in the U.S. annually at a cost of about $25,000 per infection, that's $7.5 billion a year and 13,000 deaths attributable to surgical site infections. So again, a major problem. Now, to address this, with the Institute of Medicine report in everybody's minds and the recognition that we needed to address surgical site infections as a quality measure, the Surgical Infection Prevention Project, or SIP, was initiated in 2002. And that project focused on 3 evidence-based preventive measures that would be instituted to try to improve the incidence of infections. And these all had to do with antibiotics, and I know you're all familiar with these measures. They include prophylactic antibiotics administered within an hour of incision, an appropriate prophylactic antibiotic for the procedure that's being done, and then the discontinuation of prophylactic antibiotics within 24 hours of the end of the operative case. Now, there was a publication by Pat Stellinger and colleagues who worked on this initiative in a multi-center trial, and you can see here they looked at these 3 measures plus a number of others that they implemented, and we're going to talk about all of these later, but the compliance with these measures increased significantly. Some of you may be familiar with Dale Bratzler's paper looking at the baseline data when this project started, and performance really wasn't good in a lot of these areas. Discontinuation of antibiotics was really poor, and that has been a little slower to improve than some of the other measures. But you see over time, essentially every measure improved in terms of compliance. And that the compliance with these interventions was associated with a decrease in surgical infection rates. And you see here in these 8 centers that were participating, they went from a baseline rate of to about 2.6% to about 1.7% in 11 months. So a pretty remarkable improvement that went along with the compliance with these interventions. So with the demonstrated improvements in compliance, that kind of set the stage for the Surgical Care Improvement Project, or SCIP, showing that you could make improvements in compliance and improve outcomes by incorporating a couple of measures into our practice. In 2005, really all the organizations that make a difference to our practice got together and decided we need to improve the safety of surgical care through reduction of postoperative complications. So in 2005, SCIP was initiated. The ultimate goal was to reduce surgical complications by 25% by 2010. Now, SCIP did a lot more than just address surgical site infections. Perioperative MI, postoperative pneumonia, and venous thromboembolism all came under the SCIP umbrella, but again, today we're just talking about surgical site infections. Now, with this, we all recognize we've had an increase in transparency and accountability in terms of public reporting and pay for performance that's gone along with the advent of these initiatives. And this shows the voluntary reporting of hospitals. Over here, the number of hospitals reporting, and along the x-axis, the quarter. You see that when the Deficit Reduction Act of 2005 proposed that hospitals need to start reporting these measures to avoid losing annual payment, hospitals started reporting. So we really need to do that, and so it has significantly increased the transparency of healthcare outcomes. Now, there are a lot of measures that are being reported, and as I showed you with that SIP paper, there are a lot of measures that have been instituted along the way. As far as SCIP is concerned, the 3 antibiotic measures are important, and then there have been several that have been added. There have been some that have been taken away, but this is the current active list. The antibiotic measures cardiac surgery patients with serum glucose controlled on the morning of post-op day 1 and 2, appropriate hair removal, urinary catheter removal by post-operative day 2, or else there has to be a reason documented, and then active warming used or the demonstration of a temperature above 36 degrees within 30 minutes prior to or 15 minutes after anesthesia end time. So maintenance of normothermia. So these are the skip measures, and these are all reported, and here's where the more of the transparency comes. If everybody can look at their performance, or patients can look at the performance of different hospitals on the Hospital Compare website. And this is an old slide. We're doing better than 85% in this measure now, but you see this is from back in 2006. But this is what you'll see, and I think many of you have probably been on this website before, but anybody can get on here and compare hospitals in their area and see how they're doing on these measures. And this is used for, well, by patients to kind of decide where they want to go for health care, and it's also used by CMS for our compensation for our care. Over 4,000 hospitals contribute to this database. Now, value-based purchasing pays us for performance on the clinical processes of care and the patient experience of care as well. So our compliance with the skip measures and the patient satisfaction on the HCAHPS surveys will determine our hospital's compensation. And there's also the final inpatient payment rule. CMS makes their final rule periodically and update what they decide are preventable conditions for which they won't make additional payments. And in the realm of surgical site infections, these include SSIs after certain elective orthopedic procedures like total knee arthroplasty, laparoscopic bariatric surgery, and mediastinitis after CABG or cardiac implantable electronic device procedures. So there is a lot at stake for the hospitals as well as the patients when we have surgical site infections. Now I'm going to go over some basics. Again, those of you who work in infectious disease or infection control, this is not going to be anything new for you, but just to get everybody on the same page, there are strict definitions of surgical site infections as defined by CDC. We have the category of superficial incisional SSIs. These are relegated to the skin and subcutaneous tissues, and these are defined, as you see here, infection within 30 days after the procedure, either purulent drainage or clinical evaluation with pain, swelling, redness, or heat, or an incision that's deliberately opened by the surgeon, unless they go ahead and culture it and it's negative. Or if the surgeon says it's an infection, they'll accept that and it's an infection. A deep incisional surgical site infection is involving the deep soft tissue at the site, so below the subcutaneous in the muscle or fascial layer, and it's diagnosed by basically the same criteria. And then the organ and space infections, these are more severe, usually have much greater significance for the patient in terms of staying in the hospital longer or requiring additional procedures, and they have their own definition. It used to be that the risk for surgical site infections was defined primarily by the wound classification as listed here. And when I was training in surgery, this was kind of what we had to work with. We either had a clean wound, clean contaminated, where there's a minor break in the field or entering the respiratory or GU or GI tract, but not spilling anything. Contaminated cases were those where there was GI spillage or the presence of infected urine or bile or a major break in technique or some trauma cases. And then dirty or infected cases when you encounter an infection like perforated appendicitis or perforated diverticulitis. And along with these wound classifications, there was a graded increase in infection risk. And in all the textbooks that I had when I was training, this was the risk that you saw, ranging from 1.5% up to 40%. And this was based on some fairly old data, as you can see. Now, in the 90s, this was updated. In a large subset of patients, they got rid of the dirty and infected category, but you see it still held that when you go from clean to contaminated cases, there is an increase in the risk of a surgical site infection. But there is a lot more to it, and everybody recognizes that. There's a list of Ssi risk factors that I give here, and you can probably add a lot more to this list, but they range from chronic comorbid medical conditions to environmental factors. Things we do to treat the patient may also contribute to the risk. And so there have been attempts over time to try to get more specific about predicting the risk of infection. The study on the efficacy of nosocomial infection control, or CINIC, looked at this and identified independent risk factors for infection with clean cases. And these included abdominal operations, operations lasting more than 2 hours, the presence of a contaminated or dirty wound, or 3 or more discharge diagnoses. Now, later on, NNIS developed a risk index that tried to get a little more specific, and they had operation-specific risk. That was based on the duration of the operation, but each operation lasts a different amount of time, so that was separated out by the operation. A surrogate measure of the comorbid medical conditions is the American Society of Anesthesiologists Physical Status Classification Score, which I'll review in a moment. That was used in this study, and it was found to be more accurate than the CINIC index. Now, the ASA classification is listed here. ASA1 are normal, healthy people. ASA2 are those with mild or moderate systemic disease but no functional limitations. And the ASA 3 through 5 are the ones that start to have more problems after surgery, more problems of all sorts. But these are patients with severe systemic disease with functional limitations, life-threatening systemic disease, or the ASA 5 are those who aren't expected to survive regardless of whether or not they have surgery. And then the E code is added if it's an emergency procedure. So based on these factors, whether it's a contaminated or dirty wound, ASA class 3 through 5, or if the operative time is longer than the 75th percentile for that operation, you can see that the risk prediction gets a little more specific, and there's a little more gradation. So in a clean case, it can range from 1 to 5% depending on which of these risk factors are present. Same with clean contaminated and the other classes. So this has been used more widely in terms of risk assessment. Now, with the advent of laparoscopic surgery, that's recognized as having lower risk. So the M class here, those patients with no risk who are done laparoscopically, you see that those are lower than even the patients who have no other risk factors. So that's a recognized improvement in our risk. Now, as I said, we are all aware that there's more to this, and we still haven't put our finger on it. And we at Denver Health have collaborated with Intermountain Health to try to identify or better improve SSI risk stratification. And essentially, we haven't found any new models or come up with anything specifically, but if you look at what a focus group of experts in this area identify, we know that the current models are inadequate, and there are inappropriately weighted or an excessive number of factors in some scoring systems. The infection rate assessments vary based on the methods of documentation, the completeness of the audit, and consistency in assessing the risk factors. And there are other categories of risk that might be considered and currently aren't in most models, such as emergency versus elective surgery, well-managed versus poorly managed or undocumented comorbidities, compliance versus non-compliance with medical care, and scheduling considerations. So this is an area for future research that we and Intermountain Health are involved in, and will probably continue to evolve over the coming years. All right, so let's start talking about prevention. And I'm going to start going over the, as we call them, the getting started measures. The prevention targets for this project will focus on NHSN-defined colon procedures. And the outcome of interest that we want to reduce the SSI standardized incidence ratio, I'm going to go over that in a minute, by 40% by the end of 2013. The process measures we're shooting for are 95% or better adherence rates to each of the SCIP infection prevention process measures by the end of 2013. Why are we focusing on colon? Because colon procedures have about the highest rates of SSIs of any elective procedure that's commonly done. It is a commonly performed procedure around the country. SSIs after these procedures are associated with significant morbidity and mortality. There's a significant cost to the complications. There are evidence-based preventive measures that exist that have been well studied and widely reported. And there is mandatory reporting in some states and now by CMS using NHSN. So that's why I've chosen colon. How is colon surgery defined? Well, I don't expect you all to write these codes down, and this information will all be available to you afterwards for reference. But it's colon surgery is defined as incision, resection, or anastomosis of the large intestine. This includes large to small and small to large bowel anastomosis. Does not include rectal operations. Now, the standardized incidence ratio is the observed number of SSIs over the expected number of SSIs. The observed rate of infections is calculated by finding out how many patients had an infection after an operation, multiply that by 100, and divide that by the total number of operations performed. So if you have 2 infections out of 100 colectomies, 2 times 100 is 200, divided by 100 is 2, so it would be 2%. Now the expected number of SSIs, you calculate the number of operations in the procedure risk category times the NHSN rate and divide that by 100. Now I'm not going to go through that because that gets a little more complicated and we don't have time for that in this webinar, but again, you will have access to the information to calculate those data. Now I'm going to go through these measures individually to talk about the evidence behind them and how we want them to be reported. So first, prophylactic antibiotics given within an hour prior to incision. This is one of the original measures from the SIP project in 2002. And the data, if you look at literature on this, this goes back to a study that was published 20 years ago, so the data were from even before that. But what this demonstrated is if you look at the time from the administration of the antibiotic to the incision, if the antibiotic was given within an hour of incision, that was the lowest infection rate. Now, within 2 hours is almost as good, but these are both superior to any time after the incision. And it was given 3 or more hours before the incision. That was no better than giving it 5 hours afterward. Now, these data have been replicated more recently, and this was a study published in 2009, and you see the same type of curve. So the sooner you give the antibiotic before the incision, the better, and afterwards you can't count on the efficacy of the antibiotic. So the goal is to get the antibiotic into the patient so that it can distribute into the wound area before the incision is made. Now the reporting of this is, for the numerator, the number of patients who received the prophylactic antibiotic within an hour, and 2 hours is necessary for vancomycin or fluoroquinolones. The denominator is all the patients for whom prophylactic antibiotics are indicated. And if your timing information isn't recorded in the operative record, you will miss that measure. Now the next one is the appropriate prophylactic antibiotic. Now, antibiotic prophylaxis has been debated for some clean operations such as breast procedures and hernia repair, But essentially, in every type of operation in which it's been studied, there has been a demonstrated benefit to giving prophylactic antibiotics compared with placebo. And depending on the risk of the operation, the number needed to treat to avoid an infection varies. But you see colon, where there's a higher rate of infection, fewer patients needed to treat to show a benefit, whereas in total joints, it may be a lot more before you can demonstrate it, and the same with breast and hernia cases. Now, regarding colon surgery, there are approved antibiotic choices that the CMS has identified that have been shown to reduce the risk of colon surgery, and so these are the ones that need to be used to get credit for this measure. The first-line antibiotics include cefatitin, cefoxitin, ampicillin, sulbactam, or ertapenem. I didn't include a slide here, but ertapenem was studied against cefatitin in a large prospective randomized study in the New England Journal of Medicine and was shown to be superior. And it does have advantages in its once-daily dosing. So a lot of hospitals, including ours, have gone to that as a first-line agent. But there are other acceptable antibiotic choices in that area. And patients who have beta-lactam allergies, again, several antibiotic choices for them. Now, what has been shown is if you use a non-standard antibiotic regimen, that is, one that doesn't comply with any of those recommendations, there is an increased risk of surgical site infection. So you want to stick with the approved antibiotics, both to get credit and so your patients will do better. So in reporting the appropriate antibiotic choice, it's the number of patients who receive the appropriate antibiotic over all patients for whom prophylactic antibiotics are indicated. Now, the third measure we'll be reporting is the discontinuation of prophylactic antibiotics within 24 hours. Now, I mentioned Bratzler's paper on the baseline characteristics when the SIP project started. You see that in this study, if you look at how many were discontinued within 24 hours, it was only 40%. So 60% of patients were having antibiotics beyond 24 hours, and included about 10% who were after 96 hours. There really isn't any literature showing a benefit to prolonged administration of prophylactic antibiotics. Most studies have confirmed the efficacy of less than 12 hours of post-operative prophylaxis. Many studies have shown the efficacy of a single preoperative dose, and essentially, whenever compared, a shorter course of prophylactic antibiotics has been as effective as a longer course. Now, this is a review of all kinds of studies, and what we're looking for is a difference from the number one line. You're not seeing any. So all studies, if you pool them, you find no difference in the efficacy of single versus multiple dose prophylaxis. And there can be downsides, and in this study in cardiac surgery patients, acquired antibiotic resistance was a problem identified in 6% of patients. So that's a downside to the prolonged administration of antibiotics. I will note that in SCIP, you are allowed to give 48 hours of antibiotics in cardiac surgery patients. Now, when reporting the appropriate discontinuation of antibiotics, once again, the number of patients who received them and had them discontinued in 24 hours, or 48 for cardiac patients, from the end of surgery, over all patients who received prophylactic antibiotics. And again, there's no evidence that they're necessary after wound closure, and you should consider stopping them prior to 24 hours. The next measure we're reporting is appropriate hair removal, and that is not using razors for hair removal prior to surgery. This has been studied by a lot of different investigators. 11 prospective randomized clinical trials summarized by the Cochrane Review, and there is no difference between hair removal versus no hair removal, first of all. And clipping or creams are both superior to razors. So basically, anything other than a razor is acceptable for hair removal. And again, reporting this, number of patients who didn't have it removed or had hair removed with clippers over all surgical patients undergoing the procedure. The final measure in this area is the use of active warming to maintain normal thermia of patients. Now, warming makes a lot of sense, theoretically. Hypothermia is common in surgery because the patients have impaired thermal regulation due to anesthesia. There's altered heat distribution and exposure of the patient in an often cold operating room. Hypothermia increases susceptibility to infection because of vasoconstriction, decreased oxygen delivery to the wound, and impairment in immune function and wound healing. An early study in this area focused on colorectal surgery patients. There were 200 of them randomized to routine care in which they were allowed to become hypothermic versus warming to try to maintain normal thermia. They controlled for IV antibiotics, for the amount of fluid patients got, and for the administration of oxygen. They used forced air heat and fluid warmers to maintain or to warm the patients. They did wound evaluations every day for 2 weeks and measured collagen deposition in the wounds at the end of 2 weeks. These are the temperature curves from the two groups, and you see that the patients who were actively warmed hit a low temperature just below 36 degrees about an hour into surgery, but by the end of surgery, they averaged about 36.5 degrees. This is compared with the patients who were allowed to get cold as per the standard care, and they averaged below 35 degrees by the end of the surgery. And they took them several hours to get back up to the point where the other patients had left the operating room. In this study, the infection rate was 6% among the patients who were warmed, compared with 19% in the patients who were allowed to get hypothermic. The asepsis score is a measure of the clinical evaluation of the wound. It's much lower in the warmed patient. Collagen deposition was better. And there were a couple of other outcomes that were reported and were different. It's not clear whether days to solid food or suture removal have much to do specifically with surgical site infection, but they may. But the hospital length of stay was 3 days shorter in the warmed patients. In this study, they looked at the risk factors for surgical site infections, and after tobacco use, hypothermia was the most profound risk factor. Now, another study published in The Lancet about 10 years ago looked at clean surgery patients. The other one was colorectal. This was clean surgery like hernia repair or breast surgery, and they had 3 groups in this study. There were those who had routine care, those who had local warming with a radiant heating device, and then those who were systemically warmed using forced air heat. The heating was started 30 minutes preoperatively, and the patients were followed up at 2 and 6 weeks postoperatively. In this study, whether they used the local radiant heat or systemic warming, both of them had a significant increase in their core temperature. And the wound infection rate, when you compared both warming groups together versus the other group, it was 5% in the warmed groups versus 14% in the standard care groups. So again, a demonstrated benefit to warming the patients even in clean operations. So normothermia should be reported as the number of patients with post-op temperature over 36 degrees, and you want to look for the first temperature obtained upon arrival to the PACU. And the denominator is all surgical patients undergoing the procedure who are not excluded from normothermia. So in summary, the getting started outcome is going to be the colon, surgical site infection rate, and the process measures are prophylactic antibiotics within an hour, the appropriate antibiotic, discontinuation within 24 hours, appropriate hair removal, and active warming. Now, in the working harder category, one thing that we've identified is to share the surgical site infection rates with your surgeons and operative team. And what I found as a surgeon is that once we know what our rates are and how we're doing as a team, we start to look at it more critically and take action. So as long as you're collecting all these data, start sharing it with people in your hospital if they're not already seeing it. Show it to the individuals, show it to the OR team, and get everybody working together on improvement strategies. Now, for those of you who have already gotten all these other things down, I'm going to go over a few measures that we consider to be ahead of the curve, and I'm going to talk about the evidence that supports all of them. First of all, administration of prophylactic antibiotics, in addition to getting them in within an hour before the incision and picking the right antibiotic from the list, remember that many patients will require different dosing, and one specific area is morbid obesity. Patients may have a high infection rate after bariatric surgery, and in this study, this was done, published in 1989, it was that long ago that it was recognized that the dosing made a difference in these patients, and if patients received ANSEF for their bariatric surgery, if they received 1 gram, the infection rate was about 17% versus 6% if they received 2 grams. So the issue here is increasing the dose of antibiotics based on the patient. Now, repeating antibiotic dosing may be important in patients who are undergoing prolonged operations. And again, this is an older study published in the 90s, but you see here in patients whose operations were lasting more than 3 hours, if they had a single dose of cefazolin prior to the surgery, they had a much higher infection rate than those who were redosed during the operation. Now, if it was under 3 hours, there was no difference. And if you use an antibiotic that sticks around longer, like ceftazidime in this study, it's not an issue, but pay attention to the antibiotic that's being used. And if the operation is lasting a longer time than you expect, or longer than the half-life of the antibiotic, then it should be redosed. This has been shown in long cardiac operations as well. In cardiac surgery, there's a 38% increase in SSIs for every extra hour that the operation lasts. And in this study, redosing every 4 hours would have reduced the surgical site infections by 16%, according to their estimate. Now, skin prep is another area that we should pay attention to. There's been a lot written about this, and this is from a recent publication in the New England Journal. In this prospective randomized study, about 850 patients undergoing clean contaminated surgery were randomized to chlorhexidine with alcohol, or ChloraPrep, versus povidone iodine. And you see here the outcomes from this study. In the ChloraPrep group, there were significant improvements in all surgical site infections, 9.5% versus 16%. And this held true for superficial ones, which were cut in half, deep incisional infections as well, from 1% to 3%. Now, the organ space infections weren't affected by the skin prep. And the reason for that is that organ space infections are generally coming from the area where you operated. If you're entering the GI tract or GU tract, as they did in these clean contaminated operations, the deep space infections are probably coming from that, whereas the more superficial and even the deep incisional infections are generally going to be coming from the skin flora. Sepsis related to the surgical site infection was lower, although not statistically significant in this study. A meta-analysis of prospective randomized studies that included 5,000 patients suggested the same thing, that chlorhexidine is superior to povidone iodine in reducing surgical site infections. Now, mechanical bowel prep is something that is often debated, and there has been a lot written about this, including a recent meta-analysis of 14 prospective randomized studies enrolling nearly 5,000 patients. And again, going back historically, patients were given a bowel prep, and any of you who have had your screening colonoscopy have gone through this, where you drink a couple liters of Go Lightly and complete the prep, and then the patients would go in for surgery a little bit dehydrated, feeling awful. And when you look at the data, there doesn't seem to be much benefit to the patient. No difference in anastomotic leak rates, no difference in pelvic or abdominal abscesses or wound sepsis. And if you consider all SSIs, the groups not getting a mechanical bowel prep did better. Now, if you exclude small trials, there was a higher risk of deep pelvic abscesses in the group that didn't get a mechanical bowel prep, and part of this is combining patients undergoing colon and rectal operations. There aren't enough data on rectal surgery specifically, but I think when you look at the bulk of the literature, it favors not doing mechanical bowel prep for patients undergoing colorectal or colon surgery. Sorry. Now, one interesting area that's been debated quite a bit recently is the use of high oxygen therapy for patients undergoing colon surgery. And this dates back to studies in the 80s and 90s looking at the effects of oxygen on wound infections and wound healing. The bactericidal activity of neutrophils is oxygen dependent. And in studies done in animals as well as humans in the 80s and 90s, wound oxygen tension was inversely correlated with wound infection rates. So the more oxygen you got into the wound, the lower the infection rates would be. So it was hypothesized that supplemental oxygen would decrease wound infections. And this is data from a paper that was published in the New England Journal back in 2000. They enrolled 500 colorectal surgery patients. They randomized them to two groups: the normal oxygen levels under anesthesia, which is 30% oxygen and 70% nitrogen, compared with the hyperoxia group, and that was 80% oxygen with 20% nitrogen. This is administered throughout the operation and for 2 hours post-operatively in the recovery room. The IV antibiotics, the hydration, and the warming were all controlled in this study. And they did wound evaluations every day for 2 weeks and measured collagen deposition in the wound. What they found in the two groups, which were well matched, the oxygen tension was higher in the high oxygen group, which you would expect. The infection rate, significantly lower, 5% versus 11%. Collagen deposition, no different. Hospital length of stay, no different. But that main finding was the infection rate was cut in half. Now, a study that performed a similar protocol was published in JAMA in 2004. Now, in this study, it was 165 patients, not the 500, and these were all types of surgery, not just colorectal. Their protocol was 35% oxygen compared with 80%. They did it for the same time period. In this study, they found a much higher infection rate in the high oxygen group. They also found higher rates of reoperation and longer lengths of stay, which is hard to imagine that oxygen is making the difference there. Well, there were a number of criticisms of this study. One was that they did a retrospective chart review to identify infections. It was a small, very heterogeneous population, and they didn't control for some elements that are understood to make a difference in infection rates, including anesthetic and fluid management, the temperature of the patients, and pain control. Moreover, the groups were not well matched. The obesity rate, the operative time, blood loss, fluid volume, and the need for post-operative intubation were all greater in the high oxygen group. This was the group that had the higher infection rates and longer lengths of stay. So that study has been discounted a little bit by people who have been looking at this literature. Now, a study published a year after that in JAMA looked again at just colorectal surgery patients, 30% oxygen versus 80%, same kind of protocol. And in this study, again, the high oxygen group did much better, lower infection rates. They did have a longer hospital length of stay, not statistically significantly different, but the infection rate was the key finding here, so lower again. Now, as this has been unresolved, this has been looked at again. A study published a couple years ago in JAMA called the Proxy trial enrolled 1,400 abdominal surgery patients. Same thing, 30% oxygen versus 80% intraoperative plus 2 hours after. Surgical site infection rates, no different. Deep infection rates, a little bit different, but not significantly. So these studies have been subjected to meta-analysis, and what has been concluded was that the weight of evidence supports using the 80% oxygen, particularly in colorectal surgery patients, and that's the group that's been most rigorously studied. The groups that have mixed surgery types haven't found the same, haven't come to the same conclusions, but those that have focused on colorectal surgery, those patients do benefit from high oxygen. One more area I want to go over is the eradication of nasal Staph aureus. A lot of us carry Staph aureus in our nares. Carriers seem to be at risk of Staph aureus surgical site infections. And intranasal therapy with mupirocin to eradicate the Staph aureus has been shown to prevent sternal wound infections after cardiac surgery and to prevent surgical site infections from MRSA in orthopedic patients. In a prospective randomized study published in the New England Journal about 10 years ago, nearly 4,000 patients were enrolled. They had overall a low rate of Staph aureus infections, but if you looked at those patients who were carriers of Staph aureus, there were significantly fewer Staph aureus nosocomial infections among this subgroup when they had the Staph aureus eradicated. So this was felt in an accompanying editorial, felt to be a potential cost-effective strategy. Again, it's felt that you need to focus on the patients at highest risk for this, and those include cardiac surgery and joint replacement patients. Another area of interest is transfusions and postoperative infection. The literature base on transfusions and their adverse outcomes is growing by the month, and there are literally hundreds of articles that demonstrate relationships between transfusion and postoperative infections, and they're all consistent in that transfusion is associated with increased post-op infection rates. And it really doesn't matter what type of surgery you're looking at, the association is there and it's very clear. Now, the causality of it has been harder to demonstrate because there are reasons patients get transfused in the operating room, and some of them being confounders like shock and things that are going on that would make a patient anemic. But the association is very clear. Now, in bowel surgery, like we're talking about here, this multi-center study looked at nearly 1,500 patients, and looking at independent risk factors for surgical site infection, transfusion was right up there with another infectious process as being a major risk factor for a postoperative surgical site infection. Now, the issue of shock and so on it holds true when patients have a large volume transfusion, but if you look at low volume transfusion of leuko-reduced blood, many people might think, well, that's pretty harmless, and why don't we do it? Well, the American College of Surgeons NISQIP database is a huge database that's very rigorously controlled. There are nurses who collect data in a standardized way across the country. They audit charts according to formulas, and they get ongoing training. So the data in this database is about as good as you're going to find in any large database. And in this study, looking at over 125,000 patients in 121 hospitals, transfusion risk index was calculated, and they looked at all kinds of adverse outcomes after surgery. What they found was patients receiving a single unit of packed red blood cells had higher rates of SSIs, as well as UTI, pneumonia, sepsis and septic shock, overall morbidity, and 30-day mortality. After adjusting for other confounding factors, 1 unit of packed red blood cells was found to significantly increase the risk of mortality, overall morbidity, pneumonia, and sepsis or septic shock, not surgical site infection. Transfusion of 2 units increased the risk for all of the above outcomes as well as surgical site infections. So even a low volume transfusion can have a significant adverse impact. So in summary, these measures that we consider ahead of the curve include antibiotic dosing per weight and redosing during surgery, prepping with chlorhexidine rather than povidone iodine, giving high-flow oxygen, especially in colorectal surgery, eradicating Staph aureus from the nose prior to cardiac surgery and joint replacement, avoiding transfusion, and keep looking for other factors. That's all I have to say, and I think at this point we'll open it up for questions.
Great, thanks, Dr. Biffl. If anybody has questions or comments, the best way to get those across during the webinar now is to type them into the Q&A box, which if you don't have it displayed already, there's a drop-down menu at the top of your screen, and you can select to view and use the Q&A box. So right now we don't have any questions. And then also if you're down the road and have questions come up, please send them to us so we can get them answered and included in FAQ for this topic. And you can send those to admin@henlearner.org. So I still don't see any questions. I did want to just point out that the introduction to the hospital-acquired infection webinar that we had last week is posted on the website at www.henlearner.org, so you can go view that if you weren't able to, or share that with others that weren't able to join as well. So we do have one question that came in. I think it's still on its way in from Linda Onstad. It's a comment on chlorhexidine versus betadine. I'll see if we can get the rest of the comment in, but Dr. Biffl, did you have anything in response to using those two agents?
Well, I would just say that, chlorhexidine and betadine have been widely used, and they're often used interchangeably in the operating room. But when you look, I think that the recent evidence, particularly with regard to ChloraPrep, but the bulk of it suggests that chlorhexidine is a superior prep. And so we're moving to that in our hospital, and I would suggest using it.
Okay, great. I'm going to see if we can get the line unmuted. So Linda had an additional comment. We can hear that. Oh, she just sent it. She typed it in. So it said, we have reviewed the literature of chlorhexidine and have decided to allow surgeons to use either formula. The 3M product, DuraPrep, is favored by a lot of the surgeons. It is not the same as Betadine. Okay. Great. Thanks, Linda, for that comment. Dr. Biffl, did you have anything else?
Well, I think that DuraPrep has alcohol in it, which probably makes a difference there. But I think, if you're talking about chlorhexidine versus betadine, again, our reading of the literature here is that chlorhexidine is superior, and we've, essentially hospital-wide, it's the favored prep. But, we're not going to use that as a measure against people if they're using DuraPrep or iodine.
Okay. Okay, great. Thanks, Linda, for that comment. I think Yes, we're still going to see if there are any comments over the phone. We're going to see if we can unmute all the lines, and if any of those come through. Right now we don't have any other questions in the Q&A box. Just 1 minute and we'll see if we can get those unmuted. Doesn't look like we're able to.
Fritz Kahn, if you would like to ask your question, you are unmuted.
Oh, did we have one? Fritz?
We do, yes, and I have unmuted him, and I will be working on unmuting the others who have questions as well.
Oh, okay, great. Oh, okay, there are a few questions. I'm sorry, there were a few more questions that came in. So, when will the presentation be posted? So, thanks, Sherry, for that question. We just have a few edits and things we need to do to get them available for posting, but they should be by the end of the week. This recording of this presentation should be posted. So, we'll send a notification out for that as well. A follow-up from Linda's comment. The comment is the study only compared betadine and not the betadine with alcohol. Oh, okay, okay. Thank you.
And Linda has also been unmuted as well if she would like to continue the conversation.
Oh, great. Linda, are you there?
I am. Sorry,
here.
I don't mean to be argumentative, but it's just a personal thing that we went through when we were evaluating the products here, and I think that sometimes the competition between these two products, everybody points fingers, and there's been a lot of conversations about which product is superior, and sometimes I think the data that's used to compare is not exactly fair. So that's my main comment.
Duly noted. I think that's fine.
Okay, thank you.
Fritz, are you there?
Yes.
Okay, we've got your question here, but if you wanted to go ahead and pose it to the group now, that would be great.
Our question is, has the literature demonstrated any benefit to pre-op CHG showers and its impact on overall surgical site infection rates?
I don't think that the literature is really that compelling for the use of showers. There may be small patient groups in which there is a higher impact, and I've got Connie Price here with me. Maybe joint replacement, but I don't think the literature is really that clear.
I think it's probably some benefit on patients who are colonized with something like Staph Aureus, and if you're not doing screening, doing Hibiclens baths prior to surgery might be something that's a benefit, but the data really haven't informed us which way to go, whether it should be a standard or not.
Thank you.
Okay, great, thanks. So I think that is all the questions we've got now. Again, if anything comes up, please email them to us at admin@henlerner.org. And with that, I'd like to again thank Dr. Biffl and thank everybody for joining, and I hope you have a good rest of your week. Thanks, everyone.